Welcome everyone to the EAA and the EANZ live Q&A webinar for Eczema Awareness Month 2023. My name is Michaela Pretorius and I am a Corporate Membership Officer for the organisations. Thank you so much for taking the time to join us today. We hope you learned some great tips, information and resources for how to effectively manage your eczema, either for yourself or for your loved ones, including new eczema treatments. To begin, I'd love to introduce you to our panellists for the day, our EANZ Rep and eczema carer Vanessa Jenkins, as well as healthcare professionals Dr. Kate D'Ambrosius and Dr. Laura Weller. Our fantastic panelists will be providing you with insights into eczema and new treatments currently in this space, as well as some awesome tips on how to navigate the condition both as a sufferer and a carer. In today's session, we will learn more about the organisations, events coming up this year and how to get involved, as well as insights from Drs. D'Ambrosius and Weller before we head into a Q&A session. If you have any questions while the panelists are presenting, please be sure to write your questions in the chat on your control panel. We will then be responding to these questions in our Q&A time. If we do run out of time and you're unable to answer your questions, please do send them through via email or give the EAA a call. Our details are on the website. We'll now be handing over to Vanessa Jenkins, who will provide a background on the EAA and the EANZ and the importance of understanding the condition for yourself and for your loved ones. Thank you, Vanessa.
Hi, everybody. Welcome. I'm here to talk about the EAA and the EANZ. So we provide support and education for eczema sufferers and carers, along with the wider community and in all aspects of eczema and its impacts. We're a non-profit organisation, incorporated bodies, registered charities in Australia and New Zealand, and we have public benevolent status, a medical advisory board, and we have international links. So every year we run 2 awareness campaigns, the one in May, Eczema Awareness Month, and the one in September is World Atopic Eczema Day. The EAA and the EANZ, we're proud members of the dermatology patient organisation Global Skin, and it's an incredible organisation. The EAA and the EANZ are also supported by multiple different companies, both in Australia and New Zealand, and some overseas as well. We also produce and distribute our Care for You eczema brochures, posters, and patient information sheets as well. So there's heaps of information in those. And we're the only dedicated magazine for eczema sufferers in Australia and New Zealand. This is absolutely jam-packed full of incredible tips and amazing things that you can do in the home to help manage your eczema. We offer our members many tips on our social media channels to help manage their condition, support for carers, and lots of information. So head there if you need some answers. So approximately 1 in 3 babies develop eczema between the ages of 2 and 6 months. So it's quite a common thing for infants and parents to have to deal with. And eczema is the most common inflammatory skin condition in adults and children, more so now than it's ever been before. So adults can develop eczema despite the misconception that it is a childhood disease. Some adults have eczema that continues from childhood, while others will experience it for the first time in adulthood. Many can experience several years of remission, only to have the eczema reappear in adult years, having been triggered by maybe a change in circumstances or a stressful situation. There is unfortunately no cure for eczema, but it can be well controlled. Managing eczema to prevent flares is a constant battle for sufferers and their carers, and can have a major impact on daily life. It's very often misunderstood and can have a significant physical and emotional toll on sufferers and their carers' quality of life. Treatment information can be conflicting and variable, and often specialists, GPs and things like that can struggle to find a lot of really good quality information to give their patients. So eczema can be challenging to the emotional well-being. Anxiety and stress are common triggers that cause the eczema to flare up. Vicious cycle begins when the skin condition ignites scratching and inflames the condition further and then causes more stress. It can impact the sufferer's family and friends. It's like a ripple effect. And 33% of caregivers report spending 11 hours per week or more on eczema management. It's quite a big thing. The eczema's true burden is often hidden from view. It's profound and wide-ranging and long-lasting. Caregivers are impacted to almost the same degree as the loved ones they care for, and as well as the children. Even sufferers who have their eczema under control can have issues with self-esteem. Seeking support from a mental health expert can help relieve short-term stress to better your mental health long-term. If you are experiencing symptoms of depression or anxiety, it's always best to reach out for support. Take the first step by going to see your GP and asking for any help that you might need. So I'm Vanessa Jenkins, I'm the EANZ rep. I also care for my husband, Reese, who's had eczema for over 35 years. I have been helping Reese with his cares for, I think, probably just over 14 years, thereabouts. And I really understand the impact of what that's like for families, for carers, and also for the patient themselves. So I'd like to give you guys a few tips on the things that I've learnt over my years in discovering this condition and all the things that come with it. So as a carer, really, really important, look after yourself. You spend so much time looking after everybody else. It's really important to maintain that balance and look after yourself as well, because if we fall apart, everything else does as well. Depression, it not only affects the eczema sufferer, but it can affect the carer as well. Even when things are really, really difficult, it's so important to communicate. And if necessary, seek outside help. If you're worried about the person you're looking after or yourself, the best option is to go and find somebody who can support you. So keep your own mental health really positive, and this can be really hard to do sometimes. Doing things like going for a walk, reading for pleasure, and getting enough sleep are absolutely vital to maintain that balance. So do your homework. Research is an incredible tool. If there's something that you're not sure about, don't waste time trying to figure it out for yourself. There are people who have done the research already. Reach out to your local support agencies and organisations. They'll be able to help you with that information. You won't be wasting a whole lot of your time, and you'll be able to get possibly more information around what you're looking for. So doctors often don't seem to be able to put the whole picture together, all the different components that come with having eczema and caring for someone with eczema. If the eczema sufferer needs a surgery, for example, there's often medication changes that need to happen around that. So being aware of the medications that the eczema sufferer is taking, what things need to be dropped, what things need to be included, and things like that. It can be really, really helpful to have more of a bigger picture than often just the GPs, what they see you sitting in front of you. So be aware of the medications. That's a really big thing. It's important to understand what medications your patient is taking, where there could be an overlap, or sometimes some medications don't like being mixed together. So just be aware of that, and often if there is some sort of side effect or something like that, you can be more in control and manage that. So let us support you too. The EAA and the EANZ is jam-packed full of information around things that you can do at home, things that you can do out in the world to manage eczema. We have a phone service, so you can ring, leave a message, and we get back to you. Otherwise, head to our website. There's tons of information on there on how to cope, different tools and strategies and things that you can use to make life easier for you guys. So just remember to be kind to yourself and to everybody else. And yeah, thank you very much for listening.
Thank you so much for that, Vanessa. I think it's truly inspiring, the fact that you've had your own experience with being a carer and you've translated this into helping others out there. And I think you make a really valid point in that, no one has to face this alone, not sufferers, but not carers either. So I'm really excited to hear from a scientific perspective now how you can manage your eczema and some tips out there for carers as well. So I'd like to introduce you to our next speaker, Dr. Kate D'Ambrosis.
Thanks, Michaela, and thanks for having me. Vanessa just did a fabulous job of giving the carer's perspective. And I'm here today to give more of the clinical scientific side, so a bit more boring, but hopefully we'll cover any questions that come up too at the end. I am a dermatologist, so I work in private practice and at a public hospital in Brisbane. And I see a lot of patients with eczema, both children who are affected and, as Vanessa mentioned, increasingly more and more adults. I thought I'd start off today just talking about what eczema actually is and what we as dermatologists see it looking like in the skin. I'll briefly touch on the causes of eczema and then look more at some clinical photos of recognising different types of eczema and how it can look in different skin types and different age groups. Briefly touch on management before passing over to Laura. So eczema, I always think it's very appropriate that eczema is derived from actually a Greek word meaning to boil over, because this is literally in the skin what it looks like. It looks like little erupting volcanoes or red, itchy, inflamed patches that when it's untreated and it's left to develop on its own, it really does get angry, quite raised, just like a little volcano would in the skin. And as you can imagine, this can get more and more irritating for the patients that suffer with these. So it does tend to usually occur in people who have what we refer to as an atopic background, and that links conditions that are quite genetically linked as well as having a pathophysiological link. And there's three main atopic conditions: atopic dermatitis, or which is really the medical term for eczema, with asthma, and allergic rhinitis or hay fever. So often when I'm talking to a patient that's newly diagnosed with eczema, I'll ask if they have any of these quite commonly coexisting diseases, or if there's a family history of any of these, because that's quite helpful to recognise that there is a genetic link to these conditions. And eczema can look very, very variable in the skin. So it can be anything from just dry patches of skin, which haven't developed that very red, angry volcano side yet, more of this red, angry, irritated look. So there's quite different morphologies that we come across, and that can change depending on the person's lifestyle, their activities, their skin type. There's many different contributors to determine what a person's eczema looks like, but it's very much that it's not the same in every person. This is the look of generally a very secondarily infected eczema. So you can see that it's quite thick, the skin's quite swollen with the inflammatory process, and there's quite a lot of crusting. So this is often very sore, painful, and can take a bit more of a treatment regime to fix than the previous types of eczema. This is more of a chronic eczema look. So this takes on an appearance of what we call lichenified skin, when the skin actually thickens in response to that chronic inflammatory drive that's existing. And this as well can take a different treatment approach and quite a longer treatment plan to clear in these cases. So what causes eczema? And this is a question that I do commonly get asked, particularly when patients come in and they're children and they're with their parents who sometimes have never had any exposure to eczema before. And I find it can be quite confronting to be given this diagnosis of what is often a very long-term, even lifelong condition, and quite a chronic condition. So a condition that we never really cure, and we instead aim to control. And I think it's really important for parents, particularly when they're confronted with this diagnosis, to understand that it's nothing that they're doing to their children's skin, it's nothing they're putting on, it's nothing they're feeding their children. In most cases, eczema is dominantly caused by genetic makeup. So there's nothing that we are doing to our children to give them this condition. And I find that that's often a very relieving thing for parents to know, because many of my patients do come in concerned that they are presenting with this because of something that they've done in their own life, or something that they're inadvertently putting on their child's skin, and that is most definitely not the case. Eczema is one of those diseases that's a very complex interplay between the underlying genetics of the individual and also the environment in which they live. So often it needs to be in, as I commonly say, the wrong place at the wrong time to come about. And as Vanessa alluded to, many people go years without knowing they have eczema, and then in their 20s, 30s, 40s, move to a different climate and all of a sudden have quite generalized, quite severe eczema. And that's not an uncommon phenomenon, and that really demonstrates how that interplay of genetics and environment, wrong place, wrong time, is necessary often to see the phenotype of this disease. I often explain to my patients, and I've actually got a diagram here on my desk when we talk about the underlying cause, I ask them to imagine the skin as a brick wall. And there's this thing called filaggrin protein, which is on the first chromosome in each of us and codes for the mortar between the bricks in our skin brick wall. So the filaggrin is key to keeping that brick wall very even and making sure the bricks are evenly stacked together to form a nice firm barrier on the outside of our skin. What happens with eczema and this filaggrin protein on the first chromosome being a little bit miscoded, for want of a better word, is that the mortar isn't forming properly. So the bricks aren't stacking or gluing together nicely, and that leads to quite a dilapidated, falling apart brick wall. And if you can then imagine that as the skin surface, that isn't forming a nice, clean, even barrier to the outside insults that we would like. And that then develops into this cascade of inflammation and falling apart of the skin that we know as eczema. There's many different environmental triggers that can set eczema off, but this is a list that I commonly see in my practice and that we often pick up patterns of causing skin irritation or breakdown. So winter weather is a very common trigger, and often change of season even, not just cold weather, but a change from hot to cold. Frequent washing and hot water is quite stripping to that skin barrier. Soap, antiseptics, low humidity or change in humidity, high temperatures, chlorine, sand and salt. So they're often the common triggers that will disturb that brick wall barrier and set off the cascade or the vicious cycle that can stir up eczema. Eczema does tend to have different patterns that it likes to affect in different age groups, and a lot of that is because of the different styles of walking and mobility that's characteristic of each age group. So in an infant or a less than 6-month-old child, they're quite immobile, but they are very focused on their face. There's a lot of saliva, there's a lot of insult to the facial skin. So you'll often see eczema affecting the cheeks and the forehead. That changes as the child becomes mobile, and they're often on their hands and knees, and then we often will see a lot of eczema on the acral surfaces on the knees that are being exposed to rough surfaces or sand or salt or being in and out of a pool. As the child walks, then we tend to see again the eczema affecting the lower limbs and the hands and forearms as they're exploring. These areas are commonly impacted. As they get older again, as an adult, it tends to morph more to the dorsal forearms and also truncal skin in an older age group. So it definitely follows a different pattern with the age group of growing up and the different skin surfaces that are more exposed to the elements. Just to give you a quick reminder of what it can look like in different age groups, these photos show that less than 6-month-old eczema, so very dominantly affecting the cheeks and the chin, areas that are in frequent contact with hands and saliva and food, irritating food substances. The preschooler often develops eczema on the lower legs, upper thighs, and it's really common for us to see eczema in these age groups that are secondarily infected due to impacts of bacteria or particles that are causing quite a degree of secondary organism infestation, if you like, in skin that is barrier impaired. Next slide. The school age kid very commonly describes flexural eczema. So these are areas of the skin often that are occluded, so behind the knees or in the elbow joints, where they can be sweat or material that's irritating the skin frictionally, and that can disturb that skin barrier, and that's where they then start scratching and that eczema cycle starts. And so this is to compare to adult eczema, which is generally truncal skin, upper back, often hands are another site, and particularly in young mums that are changing nappies, washing hands frequently, exposed to baby wipes and other irritants can really kick off the eczema. And lower limbs, again, is a common site for adults. So the management of eczema really has 3 underlying principles. Firstly, to identify the common skin irritants that the patient is being exposed to. And I think Vanessa highlighted a really important point that as a carer, your job is vital to helping the treating dermatologist or general practitioner by highlighting elements of the patient's life that may be causative in their eczema. Because oftentimes, Vanessa mentioned, we're with the patient for such a short period of time, it's really hard from that snapshot to identify what their lifestyle's like, what irritants they might be commonly exposed to, what their day-to-day life looks like. So as a carer, we would very much appreciate your help in trying to get the full picture of how we can best tailor a plan that best addresses the skin and gives us the best chance of restoring that skin barrier. That's really the second aim, is to improve that overall barrier function. We have to treat the eczema, sure, but we also have to rebuild that brick wall, so to give it the best chance of maintaining the skin barrier and keeping the skin healthy. And thirdly, is to treat areas of inflammation and active eczema, and that might be through topical measures, sometimes through intralesional measures, and sometimes even through oral or biological therapy. So there's lots of different treatment approaches to maintaining the skin eczema free. And this is a little plan we developed just to really highlight the 3 zones that eczema skin can commonly be grouped into. So often when I'm managing a patient for the first time, they'll come to me in this red or yellow zone, and I'll say, look, we're trying to get you into the green zone. We're never going to be able to be cream free because we do need to keep moisturizers and barriers into your skin at all times to prevent relapse. But at the moment, we are on an intense regime, and often these red and yellow regimes can be quite arduous, quite intensive for both the carers and the patient. But I think working towards getting into a green zone or a more maintenance, less intense skin plan is often an incentive for everyone. So this is what I generally will send a patient home with the aim of getting into that healthy green zone of maintenance therapy. I think that's my final slide now, so I'll hand over to Laura to discuss some treatment options further.
Thanks, Dr. D'Ambrosis. So I'm going to jump in here, but just wanted to say what fantastic insights, and I think that management plan is really fantastic, and would love to share this with the attendees after the fact as well. So we can chat offline, but I will now hand over to our last panelist, Dr. Laura Weller. Thank you, Dr. Weller.
Thank you so much, Michaela, and thank you to Vanessa and Kate, who have given such wonderful presentations so far. Hopefully mine won't be too boring, but it's about eczema treatment updates. So I think, you know, Vanessa has touched really nicely on the carer's perspective, and Kate has touched really nicely on, you know, what eczema is and some basic management. This is going to move a little bit into, you know, what's new, what's out there, and basically as a dermatologist, what's getting me excited about being able to treat eczema. So like Kate, I'm a dermatologist as well, and I work at the Queensland Children's Hospital and also in private practice at Ascot Dermatology. So a lot of this Kate has already touched on, and it's a little bit of a busy slide, but I think it does incorporate quite nicely as clinicians, you know, everything we think about when we see a patient with eczema. So basically we've got different treatment ladders depending on how severe a person's eczema is. Obviously, if someone's got very mild eczema, we're going to treat them quite differently to someone with moderately or severe eczema. So with mild eczema, as Kate touched on, we're looking to reduce the inflammation of the skin, and that can involve using topical corticosteroids. It can involve using things that are steroid-free, such as topical calcineurin inhibitors, or crisaborole, which is another steroid-free topical agent. None of this replaces the basic management though. So as Kate very nicely outlined, basic skincare is an ongoing, indefinite thing for every person with eczema. So using liberal moisturizer and sticking to things that are soap-free when washing, and being able to identify and avoid any triggers. When the eczema becomes more severe, then depending on what the skin is like, we may add in things like bleach bath or Condy's crystals baths to try and prevent any secondary infection. If people are having very frequent recurrences in their eczema flares, we may add in a maintenance treatment. So say, for instance, when the skin is not too bad, people may be treating hot spots of their eczema routinely with some medicated creams. And if the eczema is very severe, we may introduce things like wet wraps. We may consider things like phototherapy, and then we may consider things like oral treatments, including some of the more traditional agents, such as methotrexate, cyclosporin, mycophenolate, or azathioprine. Or we may consider some of the newer agent like Dupixent or upadacitinib, which I'll talk about in a moment. And of course, if people's eczema is really severe, we need to consider whether this patient actually needs to be admitted to hospital. So when it comes to managing eczema, basically there's a lot of different things that clinicians think about and have to consider. The other thing that also comes into play is if people have very severe eczema and we're throwing everything at it, we need to think about, if it's not working, why is that treatment not working? So for instance, are there infections that are not being addressed? Do we have the right diagnosis? Are there other things going on, such as contact allergies, that may be contributing to the eczema as well? I'm just going to touch a little bit on dupilumab or Dupixent. So this may be something that, eczema sufferers or their carers have heard about. Hopefully some people listening into the webinar, this is something you might have heard about. But for me as a clinician, this has been a real game changer for how to manage eczema. So dupilumab is our first injectable or biologic treatment for eczema. And the reason this has been so effective is because it's really trying to target the specific parts of the immune system that are overactive in eczema. So as opposed to the traditional agents, which really just try to suppress the immune system, suppress inflammation in general, this is a really specific treatment. So without getting too much into the science of it, there are specific molecules that become active and are drivers of inflammation in the skin. And dupilumab is blocking two specific types of these, IL-4 and IL-13, or interleukin-4 and interleukin-13, which we know are really key drivers of the type of inflammation that we see in eczema. So why this is so important is that it's really just blocking that specific part of the immune system, and it leaves the rest of the immune system alone. So it's not technically suppressing the full immune system like some of the other agents, older agents that we would previously use for eczema. So it's considered to be much safer, but the added bonus is it's much more effective. Aside from just improving the inflammation of eczema, there's been a lot of studies now which show that it also improves the skin barrier dysfunction. So it doesn't replace moisturizer, but what the studies have shown is that even just with Dupixent alone, the stratum corneum, or the outside part of the skin, seems to become more hydrated, which is really quite amazing. We know that if people have eczema at a younger age, they may respond better to dupilumab, and there's another marker of white cells which sometimes also can predict response. This is a case study which was very exciting for me because this was actually my first patient that I treated with Dupixent, and it was before Dupixent was really readily available in Australia. It took a lot of hard work to get the medication for this patient, but basically this was a young boy who, since infancy had basically head to toe, all over body eczema, and was literally never getting to spend any time at home because he would wind up in hospital with severe sepsis, needing quite intensive treatment of his eczema. The photos at the top actually demonstrate his skin on a good day, but they were just the particular ones that his parents were happy for us to use for publication. But you can see, even looking at those photos, him on a good day is still quite severe, and he managed to clear remarkably with Dupixent and is still on it today. For me, it was such a huge moment because it really demonstrated the difference that this medication can have in people's lives. Now that I'm prescribing it a little bit more regularly, literally I see many patients every day who describe it as life-changing, which as a clinician, that's incredibly rewarding to hear. So upadacitinib or Rinvoq is the other medication which is new to the eczema landscape. So this is an oral medication. And it's what we call a JAK inhibitor. So again, without getting too much into the science of it, the JAK inhibitors can block the same inflammatory molecules as Dupixent, but they're also blocking other molecules as well. And they're doing it from the inside of the cell as opposed to the outside of the cell. One thing that's quite exciting about this particular medication is that it has been shown actually to be even more effective than dupilumab in some of the studies. So this is quite promising. And I definitely use this in clinical practice quite regularly as well. So there's two very exciting new medications that are now available for severe eczema. I'm going to dip a little bit into some of the newer studies which have recently been published, which are looking at some of the controversies and things going on in the atopic dermatitis world. So one big question we get asked is, can treating eczema with something that's oral or injectable, can this halt the march of atopic disease? And there is some evidence that suggests it can. So when they looked at a lot of patients who'd been on Dupixent as an injectable medication, they found that actually these patients were 37% less likely to get new allergies, which if you have severe eczema, you often also do have lots of allergies to things. So that was quite exciting. And there are some clinical predictors of response to that, which I've outlined on the slide there. The other thing that was really quite interesting in the latest research is at a cellular level, looking at what's going on the skin. Even before people start to get the rash of atopic dermatitis, their skin structure and makeup appears to be abnormal. So as Kate sort of touched on earlier, there are these genetic factors that are a bit beyond our control that probably determine how the skin structure develops. And when they've done these studies, they've shown that those abnormalities seem to be present pretty much from birth. And when those abnormalities are present, and there's a family history of atopic dermatitis, people have a 54 times increased risk of developing atopic dermatitis. So, as Kate said, often people will ask, what am I doing that's causing the eczema? Well, often there isn't anything that you're doing. It's just this is the way the skin has developed. The use of moisturiser since birth has become a really big topic. So I think it was about 5 or so years ago, there were some studies which showed when babies were moisturised from birth, it reduced their risk of developing atopic dermatitis later on. There were a couple of studies in 2020 which showed the opposite. So it showed that when babies were moisturised, it didn't seem to affect whether they developed atopic dermatitis later on. But then one very interesting study last year came out that showed actually if we, aside from just using a plain moisturiser, use one that's got ceramides in it, which that's a really big keyword coming out with a lot of treatments at the moment. So the moisturisers with ceramide did seem to show a reduction in the development of atopic dermatitis later on. And that probably is because they are a little bit better at supporting that skin barrier function, but more research is definitely needed with that. Impact on caregivers, as everyone has alluded to today, this is obviously huge in people with eczema. There's been a big study just recently in the British Journal of Dermatology which showed that over 50% of people who are caring for someone with eczema spend more than 10 hours per week, which is obviously a very long time. And this can have a high or significant impact on a carer's life. And the domains that seem to have the highest impact were sleep, family dynamics, and family responsibilities. So as Vanessa touched on, I think it is very important that carers look after themselves because these are all obviously significant things in people's lives. Another little systemic therapy update. So traditional steroid-sparing medications are definitely still used, and the most common ones are cyclosporin and methotrexate. These medications will still have a place in the management of eczema, but I think as the newer treatments like dupilumab and ipatacitinib or Rinvoq come through, they will play less and less of a role. Oral steroids are not recommended for atopic dermatitis. The reason for this is they can result in a severe rebound flare in the eczema. So they are, a Band-Aid solution at best, and I literally never prescribe them. The only time that they may be considered would be if we were thinking about transitioning a patient to other medications that are not steroids. Other than that, I don't think they have a place in the management of eczema. Dupilumab or Dupixent has been approved now in the US for children from the age of 6 months. So that's very exciting. In Australia, it's only currently available on the PBS for children who are 12 years and above. However, it can be accessed for children who are younger than 12 years. At my hospital, for instance, it's funded by the hospital. So what's new? What's emerging? It's a very exciting time for eczema treatment. There are lots of trials going on and lots of research going on into new treatment options. So I've just listed a few things here. I won't go into it in any detail, but there are a few steroid-free creams which are being developed, which is very exciting. There are other biologic agents which are currently in the works also, aside from dupilumab for eczema. And apart from ipatacitinib or Rinvoq, in the US, they're also using another JAK inhibitor called abrocitinib quite routinely for children over the age of 12. These are some of the biologic agents which are working their way through the research trials at the moment. Again, I won't go into it in too much detail other than to say that they exist, and it's exciting that hopefully we will have a few more options available for our severe eczema patients. And thank you. That's my little update about eczema treatment.
Wonderful. Thank you so much for that, Dr. Weller. And I think I, for one, have learned so much about what's coming up, and I think it's really exciting, all the new treatments coming up in the eczema space as well. And thank you also for your insights, Vanessa and Dr. D'Ambrosio. I'm sure the attendees today are burning to ask a few questions, so we'll now jump into our Q&A session. I'll hand over to Dr. Kate D'Ambrosio to facilitate our Q&A session. I'll kick us off with the first question, Dr. D'Ambrosio. Can Dupixent injections cause hair thinning?
Yeah, that's a great question. I can only answer really anecdotally. I don't know any literature surrounding alopecia or hair loss being a side effect. I probably have around 50 patients on dupilumab now, and I can quite confidently say I don't recall any of my patients having a complaint of hair thinning, but I'll check with Laura and see if she agrees.
I also don't have any patients who've had any hair thinning. There definitely have been a few case reports of alopecia areata being associated with Dupixent. So that's a specific autoimmune disorder that can affect hair and cause hair to fall. But interestingly, there's been more case reports that have shown that it is helpful for those patients and has caused hair growth. So I think it's going to be one of those things where it's a bit of a watch this space, but I wouldn't say it's a common side effect or a known side effect.
Yeah, and I think there is definitely an independent association with alopecia areata and eczema anyway. So yeah, we'll definitely have to watch that space. Second question, are there any recommendations or resources we can point to help children that struggle with sleep? Gosh, that's such a common phenomenon, isn't it? Sleep disturbance with eczema. Generally, I think reaching out to associations like EAA, EANZ are fabulous resources. I myself, through them, have a few things I can actually show you here that I think many years ago EAA helped me with some little books. So often when I have patients with eczema and which we're talking about the diagnosis, often they borrow one of my little kid-friendly books and they take it home. Some have take it to school and show their teachers and their friends to think it helps with their support team around them at home, really understands what's happening in their lives with eczema. In terms of sleep disturbance, I actually use it as a bit of a marker to how successful my treatment plans are going. So at a first consultation, it's probably almost universal for a young kid with eczema to be having a sleep disturbance. I think nocturnal scratching and itching is hugely inconvenient for the whole family, siblings and parents alike. That should really be dropping off if you're treating the eczema successfully. So that's usually one of my first questions on a review appointment is to how's the sleep, how's the family sleeping, who's been up, have you noticed any scratching, is there any blood on the sheets? Because to me, if that's still going on, then I really need to look at how I can better plan a treatment, a management plan for them. But Laura, did you want to add anything to that?
No, I completely agree with everything that you said. So I think sleep is obviously a huge thing for people with eczema and a huge thing for their carers. And it definitely, if people aren't getting enough sleep, I'm optimising their treatment further.
Our next question is for Vanessa. So Vanessa, where do you even start when you have to care for someone with eczema? So have you got any pointers in that regard?
That's a great question. It's quite a difficult question, really, because everybody's skin is so different, and everybody's family unit is so different as well. I think to be informed is probably the first step. Go and get the information on the things that you can do at home, you know, things to support sleeping, the moisturizers that you need, all of that sort of thing. That's really where it's best to start, I think, is having the information available to you when you need it. So, for example, somebody is having a flare-up, whether it's a child or an adult, it's 2 o'clock in the morning, everybody's in tears, there's lots going on, and you need to have tangible information to be able to go, okay, this is how I'm going to deal with this situation. Without that, it becomes very overwhelming for everybody involved and can become extremely stressful. So yeah, definitely, I think my point would be get informed, get some information, you know, give the support agencies and organizations a call. Yeah. Not so much the internet, but you know, sources like our websites really have good information for people.
Yeah, it's definitely, it's a well-worn path, isn't it? So why not take advice from people who've walked it before?
Exactly.
Next question I've got, I might shoot to you, Laura. It's a bit hard for me. But are there any links between autoimmune diseases like celiac and eczema? We talked about one before. Alopecia is definitely linked. I'm not aware of celiac being linked. Do you know of any other direct links?
I think that's a bit controversial. So I guess celiac disease, as you know, Kate and maybe Vanessa, it can be linked to a different type of dermatitis herpetiformis, but not atopic dermatitis. But then on the other hand, people who have atopic dermatitis may be allergic to wheat, but not necessarily celiac. So I think that's sort of a complex question, but a good question. No direct link, I don't think.
Yeah, I would generally advise that. The next question, thoughts on Dead Sea salt or apple cider vinegar baths for infants? I can't say I know exactly what Dead Sea salt is. I'd suggest it's a drying agent, which in eczema works well. That's for an infected type of eczema, not so well for the usual stock standard eczema. Apple cider vinegar also has an antibacterial property, so that's probably where that association or treatment has been advised. I do tend to, my tried and tested regime is potassium permanganate or Condy's crystals, which are a Schedule 3 drug available at pharmacies, so they don't require prescription in Australia, but they're kept behind the desk. I find they work fabulously in kids' eczema and infants, which this question was quite specific for, but infants, because they do tend to carry a lot of Staphylococcus aureus, one of the bacteria that tends to drive eczema, and that's just a result of them being often on the floor, in contact with a lot of fomites. That's not something that is abnormal to be on the skin, but in an eczema patient it can cause trouble. So Condy's crystal bath work really well to keep those staph levels low and hopefully help clear the eczema. Laura, did you want to add anything to that? Do you have any?
No, I think that was a perfect response.
Next question is, any ideas on how my daughter's eyebrows can grow back? She's scratched them out now and they won't grow back. So my approach to that would be to first check if it's only eczema related. Is there another disease at play here? Because alopecia areata, as we talked about before, does have a higher incidence in atopic patients. So I'd want to be checking that there's no alopecia or actual hair loss disorder at play. Then I'd check that the eczema's been properly treated in that location. If there's any inflammatory skin drive, that can impact hair regrowth. So turning that off with appropriate treatments would be ideal. If the skin can be normalized, I think you've got a really good chance of them growing back, because eczema is not generally a scarring to that depth disorder. So it should not be impacting that hair follicular bulb and should not be causing inability to grow back. So I think promising, but I wouldn't want to promise without seeing it. Next question, Laura, I might throw this to you. My little one has severe cerebral palsy and on many medications. Could these be a contributing factor to her flares?
Yeah, so that's a bit of a tough question because it really depends what medications this little one is on, and it also depends what the skin looks like during the flares. So definitely people can get medication-induced rashes, but I do find this tends to look a lot different to eczema. So it might be worth, getting this little one reviewed when she's having a flare to see, does this look like standard eczema that's flaring, or does it look like it might be a medication, allergy? To me, they look definitely a lot different.
Our next question is from Rosie and it reads, I'm interested in the JAK inhibitor used in America, mentioned by Laura. Would this be a safe alternative for a Dupixent user who experienced the very debilitating red face reaction, which is actually quite rare, and touch wood, I haven't had too much of that side effect, thank goodness. I haven't had any experience with abrocitinib, which is the JAK inhibitor that's being used in America. Have you had any experience with that agent in the hospital, Laura?
No. So that one is not available in Australia yet, but we do have upadacitinib, which is the JAK inhibitor available in Australia from the age of 12. I have had a couple of patients who've had reactions to Dupixent that I've switched over to upadacitinib, and because it's a completely different medication, touch wood, they seem to be doing okay on it. So it might be worth, depending on this person's age, maybe considering that switch if possible.
Yeah, my experience with abrocitinib has been quite limited. I've only got 2 patients on it. Both are doing well now, but interestingly, I found it took a lot longer for them. I don't know if that's your experience also, to improve compared to the dupilumab patient, where you get that quite instant pruritus or itch relief, and then the skin follows quite quickly. But one of my patients is a needle phobic. She can't stand the idea of needles, and it's worked quite well for her as an oral tablet. Our next question is dupilumab available in New Zealand, and is it available for moderate eczema in adults? So we can talk from the Australian perspective. It is available for moderate to severe eczema in patients older than 12 at the moment. We're hoping to get it for younger patients soon. In New Zealand, I'm not aware.
So Dupixent, dupilumab is available in New Zealand on prescription. Unfortunately, it's not funded, so it is quite expensive. We're rocking around the $2,500 mark, and that's per month. So for a lot of average, $2,500 is the cost of 1 month's dose. Unfortunately, that's out of reach for majority of New Zealanders. So yeah, we're working on that. We're petitioning to Pharmac at the moment to get that one subsidised. It's very effective. My husband was on a 4-year trial for it, and it was 4 years that we didn't have to deal with any eczema, which was quite extraordinary. So yeah, I'd absolutely recommend it, but it is very expensive. So
an absolutely game-changing drug. So surely New Zealand won't be far behind with that.
We're hoping.
A question for Vanessa. What do you do to distress to help to cope with dealing with partner skin conditions? Do you have any more tips? So I think for both yourself and for your partner, how do you deal with the distress that eczema so commonly causes?
This has been something that we've had to learn. Nobody kind of said to me, oh, by the way, if you're going to commit to this, this is what you're going to be dealing with. It's really quite a major thing. So things like taking some time apart can be really helpful for both. Eczema it can be very overwhelming, both for the patient and for the carer. And I think, we like to care for the people that we love. And when we are like, are you okay? Are you okay? Do you need this? Do you need that? It can become quite intensive. So what we discovered after a few years was, just a few hours a weekend here and there is actually really, really good for our mental sanity, if you can deal with that. So another one would be to maybe be outside. It's really difficult for eczema patients to do that sometimes, but you pick a time of the day where it's not really windy or really hot and all of that kind of thing, and you just go for a little walk around the block if you need to. Being out in the fresh air, doing some breathing exercises and things like that has really helped me. I've now taught my husband how to do breathing exercises and to pressure points when things are getting a little bit stressful and stuff like that. And music's been a really big part of how we as a family unit as well as individually bring the mood down, if you will. If we've had a really rough night, our daughter who's 5, it doesn't have eczema, but she gets really itchy skin. So we have a lot of sleepless nights. And so we find that music's a really great way of de-stressing. There's a lot of other tips and tricks. So please reach out to me at the EANZ if you've got any more requests for that.
Great tips, thank you. A question from Amanda. What is the general opinion regarding bleach baths for flare-ups? Laura, do you want to take that one?
I routinely use bleach baths for eczema, particularly for younger children. I find it to be very effective. I will use it for patients that have had lots of secondary infections, and I will use it for patients who have lots of scratched skin that's just a sitter for infection. So the bleach baths have been shown to be beneficial at reducing infection, but also reducing the inflammation of the skin itself. It's important if you're going to do a bleach bath that you use a proper prescribed recipe, because there have been reported incidents of people making them too strong with quite dire consequences. So it is actually only a very small percentage of bleach. I tend to balance the pH with a little bit of salt, and then also adding some plain bath oil into the mix just to rehydrate the skin. But I use it quite routinely, and I find that it can be very effective, especially at reducing the amount of oral antibiotics that people would otherwise need.
The next question says, my daughter now has eczema all over, but also red skin, and I feel she has red skin syndrome after taking a break from topical steroids. I'm not sure what to do and how long this will last. So it sounds like, if I was the mother of this child, I would be quite stressed. I would advise getting an opinion by a dermatologist. I mean, we are trained to manage this very scenario, so I think it's probably a bit fraught for me to advise without actually seeing your daughter's skin. But I do feel that you should be able to get great advice from a dermatologist as to where to go next and how to best help her skin. Not something that you should or need to be dealing with by yourself. And I think that would be very stressful to feel that you have to. So reach out if I can be of any help in getting some dermatology care for you. The last question I've got here is, I've read that oral ceramides, I think Laura was talking about earlier, are more effective than topical ones. So Laura, do you have an opinion on this?
Look, I think there's been maybe 1 or 2 very small studies that have suggested oral ceramides can be effective. It's not the sort of thing I'd be recommending routinely until there's a lot more robust evidence. I think when it comes to topical, there's a lot of evidence available, but with oral ceramides, I think it's probably a bit of a watch this space.
Yeah, I'm not aware of any oral ceramides, but I think eczema, a lot of the treatments are most effective if we can rebarrier, restore that skin. So putting them on topically is probably the safest and most effective option that we have. Okay, so I might hand back to Michaela. I think that's all the questions we have.
Thank you so much. And I think those questions were really good. And I know we had a number of questions on here now that we weren't able to get to. So please do reach out to us, corporate@eczema.org.au. We'd love to give you some additional information and send through these additional questions to our dermatologists as well. But that is time on our Eczema Awareness Month Q&A webinar. Thank you so much to everyone who registered and joined us today. I also want to say a massive thank you to our panelists, Vanessa, Dr. Kate D'Ambrosis and Dr. Laura Weller, for offering up your time and providing some wonderful insights into eczema, upcoming treatments and how to best manage the condition.